And now a bit about what this talk is and isn't. First is a brief mental health introduction, touching on a few of the most relevant mental health conditions. It is the beginning of an ongoing conversation about mental health literacy and cultural change, but it isn't a comprehensive knowledge and response training, and it isn't everything you need to know in a nutshell. And now a bit of the mental health spectrum. We have the mentally healthy state. This is on one edge of the spectrum. This is when you are generally resilient to changes in your environment, you're generally okay. Then we have stress. This is something that everyone experiences. It's characterized by unexpected or expected events or trials that impact mental health, but people typically can come back to mentally healthy state relatively quickly. The stress is when stress is impacting an individual or their life, and it typically lasts more than typical stress. Sorry. And it can require more than the typical coping mechanisms to come back to a mental healthy state. And it can be useful at this point, interventions like psychotherapy. Then we have disease. This is when mental health has reached, well, the mental health state of a person has reached to a point where there's a diagnosable condition or disease. At this point, it is usually necessary to have some type of intervention that can be psychological, psychiatric, or medical. And I also want to highlight here that with the disease, it's possible to operate at work and at life with good care and a good treatment plan. In particular for long-term conditions or chronic conditions, with a good treatment, it's possible to operate in a mentally healthy state for the vast majority of the time. And then we have crisis. That's in the other end of the spectrum. That is when a person is experiencing feelings like those who wanted to hurt themselves or wanted to hurt others, or acute psychosis, or things like this, where the person needs external support immediately because it cannot deal with it alone. And this is an emergency situation. And in this talk, we will focus in disease. So first, what makes something a disease? First, the symptoms have to be consistent for more than a reasonable time. That doesn't mean that it has to be constant, but it has to be more days than not. And it usually is longer than 2 weeks, but can also last months. That, for example, is seen in depression that typically lasts months, or maybe you have some good days, but most of the days maybe are not that good. And it goes in this direction. Second, this must represent a significant change in the person's experience and upset. Maybe someone is generally grumpy and suddenly they are still grumpy, and that doesn't represent significant change. It has to be different from what they typically are. And third, social, occupational, educational, and other important functioning must be negatively impacted by these changes. For example, the most obvious example would be like work is significantly impacted, or relationships are impacted by it, etc. And now some common facts between all all diseases, or common facts between for all. They are all real, biologically and environmentally driven illnesses that can be episodic, chronic, or singular events. they can be preventable and are highly treatable. And critical to a mentally healthy climate and culture is access to care and community support. That's why awareness is so important, because we need awareness to create a culture of community support and care. And here we want to highlight that mental disease is highly treatable. 80% of major depressive episodes respond to treatment. And we also know that 80 to 90% of suicides are due to an underlying mood disorder. And the best way to prevent it is to treat the disorder and also restrict lethal means and avoid substance use if there's an acute threat. We also know from research that asking someone if they have suicidal thoughts does not increase risk. In fact, it decreases. And that there are 3 factors that are key: awareness, early identification, and early treatment. And this is particularly important knowing that the average person waits between 6 to 8 years to seek treatment. And we know that untreated mental illness leads to other comorbid disorders that complicate the recovery, which leads to delay in the treatment response, which that takes longer to treat when the person starts the treatment, if they started. And now we will start with the first condition. We're going to describe one by one: mood disorders and anxiety. Two of the main ones of mood disorders are depression and bipolar disorder. But we also have anxiety, which is a condition that is highly comorbid. That means that it can occur with other conditions. For example, it's possible to have depression and anxiety or bipolar anxiety, but it can also exist alone. And we know, as we said, that mood disorders underlie 80 to 90% of suicides. We want to highlight here some statistics so you know why this is important for the academic community to know this. We know that in the general population, 6.7% have depression, well, mood disorders in general, depression, bipolar disorder being the ones that we are more highlighting here. And this 6% of population has symptoms that well can be diagnosed with anxiety. And we know now, thanks to this study by Evans et al. In 2018, that graduate students have depression with rates of 39% and anxiety with rates of 41%, which is several factors of magnitude superior to the general population. So we know that it's an issue that we can improve upon. And Jim said that we also know that treating the underlying mood disorder is the most effective way to prevent suicide, other than restrictive means and avoiding substance use. And symptoms can be that the condition impacts mood, can impact body and behavior, like sleep, metabolism, and it can also lead to thought disorder. For example, when people think that they are not as bad as other persons, so they should try to get better on their own without seeking help, which really complicates seeking treatment, which complicates recovery. And some of the causes can be immune and endocrine dysfunction, can also be due to deficiencies in nutrition, sleep, or exercise. It can also be due to specific serotonergic pathways, and it has to also be connected to genetics and trauma. And here I want to highlight that no one is immune to mood disorders and anxiety. It can happen to anyone, but that it also does not mean that you're not cut out for academia. In fact, there's a wonderful example in Professor Kay Redfield Jamison. She is a world-renowned expert in bipolar disorder, and she is also she experienced the condition herself, and she wrote about it in the book An Unquiet Mind that we recommend if you want to know an example. Now we continue with burnout. This is something that people generally confuse with depression or anxiety because some symptoms are similar, but the difference is that burnout is exclusively work-related, while depression or anxiety can be related to other factors as well. Some of the symptoms include emotional or physical exhaustion, reduced resilience and adaptability, cynicism about work and colleges, and it can also go with reduced performance and concentration. And the causes are chronic stress relating to work or other activities, lack of control, bullying or toxic work environment and relationships, and it can also come from an imbalance between work and life. But the good thing is that it's highly treatable. What helps are taking breaks or vacation, also helps negotiating better hours, accommodations or communications, or building better relationships at work, and also mindfulness, sleep, and exercise. Now we continue with psychosis. This is a particular rare occurrence, but when it happens, it can really impact an individual and the community around the individual. The symptoms include disconnection from reality, bizarre behaviors, delusions that could be strong fixed beliefs that are not backed up by other people's experiences or evidence, hallucinations, they can be visual, auditory, or even tactile, chaotic or incoherent speech and writing that can also be seen, for example, in emails, now that we use emails so much to communicate. And the causes, well, we have 50% due to genetic predisposition, but the rest are due to environmental triggers. Can be due to extreme sleep disturbance, maybe not sleeping in 5 days. Also can be caused by substance use or withdrawal. For example, due to alcohol withdrawal. And I can also go with other disorders like bipolar mania or borderline personality disorders. And in this case, it's called psychotic, will be called psychotic features. And this is experienced by 1% in the general population. And what helps is antipsychotics, psychodynamic therapy, and elective behavior therapy. And as we said with mood disorders and anxiety, this is not the end of your career. Psychosis is not the end of your career. And we have a wonderful example in Professor Ellen Sachs, is a law professor that has explained her experience with psychosis in her book, The Center Cannot Halt, and we also recommend it. Now we continue with substance use disorder. At this point, I want to highlight that this is a mental health disorder. It is highly stigmatized, but it is a mental health disorder. And what converts something from substance use to substance use disorder? Well, the symptoms include daily use, binge behavior, blackouts when you don't remember, lying about the use, maybe to colleagues or friends, cravings, or the use start to impact work, relationships, friendships, and it can also impact mental health or physical health. For example, it's possible that or other conditions. And the causes, it has a very strong genetical factor between 40 to 60%, but it can also be due to a coping behavior or due to self-medication. For example, if a person has depression and is using some type of substance to self-medicate or because of chronic pain, that can lead to a substance use disorder. It can also be due to social pressure and easy access that the environment leads to dependence over time, but it can also link to other mental diseases, as I already mentioned. And what helps detoxification programs also support groups to maintain sobriety, individual or groups counseling and peer support, and also treatment of the occurring mental health disorder. For example, if it comes with depression as well, it's important to treat the two of them because the two conditions can interact, and if the two of them are not treated simultaneously, it can complicate or delay recovery. Now we continue. Obsessive disorder. The symptoms are a strong urge to perform certain routines or rituals. That will be the compulsion part. And unwanted repetitive thoughts or intrusive fears. That will be the obsession part. And the person can spend up to hours a day performing physical or mental rituals, and can also lead to avoidance of triggers or people. And the causes include genetics, trauma, and brain structural differences. And we want to highlight here some statistics. OCD is in 1% of the general population, and in the academic population is around 3.5%, which is more than three times what we see in the general population. This has been seen in research in Scan in 2018 and JISO into what helps cognitive behavioral therapy, exposure and response prevention, and medication. And we also have a wonderful advocate, an example of an academic with OCD, that is Dr. Nadine Muller. You can check both her research and her advocacy in her website. We continue now with attention deficit hyperactivity disorder. We want to highlight here that there are different subtypes: hyperactive, inattentive, and combined. Not all ADHD comes with hyperactivity. The inattentive type comes with attention problems without hyperactivity at all or almost at all. The symptoms must be present since childhood and include difficulty focusing, especially on people speaking or the body. The person can be easily distracted, misplace things, hyperfocus and perseverance to a fault, trouble acting even when intention is there, and trouble managing time, restless or fidgety. And at this point, we want to highlight that these symptoms also can occur in other conditions with depression, anxiety, etc. But it can also be that a person has multiple conditions at the same time. For example, depression, ADHD. And the causes, this also has a strong genetics factor, is 75% heritable, polygenic, but it can also be worsened by environmental factors. What helps? Medication, stimulants and non-stimulants, and that supports skills training, psychotherapy to support living with the condition, for example, to reduce frustration and negative self-talk. And we also know that while it is seen in children with a rate of 6% of children experience ADHD, only 30 to 50% of children outgrow ADHD, leading to 2.5% in adulthood. So it is still prevalent in adulthood. It doesn't necessarily disappear with age. autism spectrum disorder. Autism is a complex developmental condition, and some of the symptoms include persistent challenges in social interaction, speech, and nonverbal communication, and restricted or repetitive behaviors. And the causes, as it happened with some of the conditions before, the component is highly genetical due to no or multigenic risk, or simply unknown. What helps is medication due to the highly comorbidity with other things like depression, ADHD, or OCD. The medication helps with that part. That also helps psychotherapy and occupational or educational therapy and sensory integration therapy. We also have a wonderful example in Temple Grandin. She is an autistic advocate and a researcher. If you want to know about her life, you can check this book by Oliver Sacks, an anthropologist on Mars. And you can also check the hashtags Autistics and Academia. It's a wonderful community full of people in the spectrum that are academics, and I really recommend it. And now I want to highlight that mental disease is highly treatable, as we have seen. 18% of major depressive episodes respond to standard treatment. Awareness, early identification, and early treatment are key. And the average person waits to 6 to 8 to seek treatment. And as I said before, untreated mental illness leads to other comorbid disorders that complicate recovery, which delays the treatment response. That's why we are highlighting here these messages. Awareness facilitates also early identification and early treatment. And given these facts right now, this is really important to improve our culture regarding mental health. And a key point here also is community support, because community support and encouragement is hugely impactful for seeking care, sustained treatment, engagement, and ultimate recovery. That also means that these type of talks that create awareness are really important to improve the culture around, and also the community awareness leading to community support if someone needs treatment, or someone is talking about their treatment and is seeking for support in their environment. And a key, some key facts that we know from research to highlight how big of a problem this is in academia. We know that graduate students have up to 8 times higher rates of severe depression and anxiety by these studies in 2018 and 2019. Less than 5 years ago. We also know that those with higher IQ and education report higher rates of mood disorders and are less likely to seek treatment. And also studies from the last 5 years. And we also know that medical students and residents met criteria for burnout at 40 to 44% and depression at 30 to 50%. So we can see that this is a big problem among academics. Now, we want to highlight microaggressions. These are remarks that seem harmless, but when repeated daily and in all aspects of life, they have a cumulative effect. And they serve as constant reminder that members of marginalized groups are less than. So this slide is about the issues related to minorities, that it impacts them, and it's important to highlight this to create an inclusive a community for all. And some of the communities that we want to highlight here are women. They can experience microaggressions related to sexual harassment or violence. Well, BIPOC individuals, they can experience racism and discrimination. LGBTQ plus people, they can experience marginalization and homophobia and transphobia. International scientists, they can experience culture and language barriers. People with disabilities, they can experience ableism and accessibility challenges. And first generation scientists, they can experience economic challenges and hidden curriculum or problems due to hidden curriculum. And now some examples about microaggressions, because sometimes they are not obvious to see. And maybe this makes them more obvious to everyone. So for women, for example, it could be, a microaggression could be you're too pretty to be a scientist, or the women can experience sexual harassment by PI or lab mate. And for BIPOC individuals, people could be told things like, oh, you are the affirmative action hire, or wow, you are so articulate. Or they can be stopped a question by police or security, for example, the security of the building where they work. For LGBTQ plus people, some comments could be, haha, that's so gay. Or they can be told that genderqueer clothing choices are not professional. International scientists can be told things like, why are you complaining? Don't Asian people love homework. Or they may experience cultural communication differences with managers in a bad way. A first generation scientist, an example could be, you should have thought about money before pursuing your education. Another example of microaggression could be assuming that they can work for free or defer reimbursements. And for people with disabilities, one example would be, are you using the wheelchair for sympathy? I've seen you walk. And another would be the refusal to provide visual aids because only one person needs it, dismissing the challenge of one individual. And some remark about microaggression impact. They can cause members of marginalized groups to feel isolated and invalidated and to become hypervigilant. This can lead to anxiety and depression. And a quote to highlight intersectionality that we have here is the following. We tend to talk about race inequality as separate from inequality based on gender, class, sexuality, or immigrant status. Some people are subject to all of this. And this highlights the intersectionality between different minority backgrounds or marginalized backgrounds. And at this point, we want to highlight that intersectionality and mental health can be related. In fact, it has been seen that marginalized populations are more likely to have persistent mental health disorders and are less likely to seek out or receive treatment. Also, that LGBTQ individuals are 2 times more likely than heterosexual individuals to have a mental health disorder. It has also been seen that the status of income plus gender plus immigration can lead 3 times higher rates of depression. And it happens that also with race or socioeconomic status plus gender, that this has more than an additive effect on mental health. What we can do to improve this? One is being aware of and questioning your assumptions, our assumptions. Because microaggressions are not always obvious, we have grown up in a place that is not isolated from microaggressions, so we can normalize it. So in order to understand what is a microaggression, we have to learn and question. And also apologizing to those you might have harmed, because precisely because it's so difficult sometimes to distinguish when your assumption is actually causing the microaggression, things like that. If you realize, if you're learning and you realize that something that you did harm someone, then it's important to acknowledge that and apologize. And here, a wonderful example. So we know that the best athletes in the world spend a long time to train and also try to reach the top performance. But when they get injured, they receive immediate help, even in front of everyone to see, in the place where they are working. But in academia, it's not exactly like that. We are top performers. We want to perform to our top and we work with our minds. That's our instrument. But when our instrument gets hurt, sometimes we simply continue as usual and we don't seek help. But maybe this should be improved in the same way that with elite athletes to perform at our best. So, and now this highlights that we need this for the mind. And now some discussion time. Here, I want to ask all of you that please, if you can, fill out this very short survey so we can improve this talk. You can scan this code or check this website. And we also recommend that you come visit us or you can join. Also feel free to pass by our Dragonfly Cafe, or you can also donate if you want to support us. Thank you.